Welcome to Waking Up Tired, Narcolepsy Symptoms Explained, a limited podcast series giving voice to what narcolepsy symptoms are like from a patient's perspective. I'm Dice Spillane, and today we're closing the series with a vital perspective, the clinical lens. Joining us is Dr David Cunnington, a sleep physician and educator who spent over 2 decades listening to patients and helping decode the complexities of sleep disorders. In this episode, he shares what narcolepsy looks like from the other side of the desk, why diagnosis takes time, how clinicians think through sleepiness, and what makes narcolepsy with cataplexy so uniquely difficult to identify. We'll explore the numbers game that clinicians face, the importance of narrative history, and the diagnostic tools that help distinguish narcolepsy from its many mimics. Dr. Cunnington also offers guidance for healthcare providers and patients alike, reminding us that expertise isn't always the goal. Openness, curiosity, and collaboration are. This episode is about bridging understanding, validating the lived experience of sleepiness, and offering insight into the systems that shape diagnosis and care. Whether you're living with narcolepsy, supporting someone who is, or working in healthcare, this conversation is for you. Meet David.
I'm David Cunnington. I'm a sleep physician and I've been in clinical practice for over 20 years and see a lot of people with a range of sleep disorders, including people with disorders of sleepiness like narcolepsy. I'm based on the Sunshine Coast. I work at Sunshine Coast Respiratory and Sleep, so that's where I see people face to face, but I also see people from around the country via telehealth, which has been a great medium for people with disorders of hypersomnolence like narcolepsy to be able to access specialist care from around Australia. So one of the frustrations for people with narcolepsy is delay to diagnosis, and that's something that really comes through when I'm seeing people. And I'll try and give a little bit of context and a little bit of what it's like on the other side of the desk. So when we think about what happens when you're going to see someone, a healthcare provider, they're really, in some respects, playing a numbers game. So when you're seeing people either for the first time or people you've seen for a long time with new symptoms, you're trying to work out what's the most likely thing that's going on. Now, when we see people with sleepiness or people who present saying, I'm tired, constantly tired all the time, one of the things we need to bear in mind is if you ask the Australian population, 1 in 2 of the Australian population will say they're tired all the time. So if you're working in primary care, say as a GP, every second person you're seeing is feeling tired. Now, when we think about narcolepsy with cataplexy, that occurs in 1 in 3,000 people. So if you're playing the numbers, 1 in 2 people are sleepy, but only 1 in 3,000 are going to have narcolepsy. So that's 1 in 1,500 people of those who come to you saying that they're sleepy are actually going to have narcolepsy. So you're not going to jump to, hey, this might be narcolepsy as the first thing. And in fact, you shouldn't if you're the healthcare provider, because it's 1,500 times more likely to be something else than it is to be narcolepsy. Now that's really frustrating if you're the person with narcolepsy and you want to get to the nut of it straight away without sort of working through a list of things. But it's just an unfortunate reality. Because if we then look at people who meet the diagnostic criteria for a central disorder of hypersomnolence, so narcolepsy with cataplexy, narcolepsy without cataplexy, idiopathic hypersomnia, hypersomnia associated with other medical conditions, for example, that's about 1 in 10 in the population. And so it's still really common. And still think of that as then, okay, well, you've got 1 in 10 in the population meeting that central disorders of hypersomnia definition, but only 1 in 3,000 having narcolepsy with cataplexy. You're still 300 times more likely to have one of the other disorders than you are to have narcolepsy with cataplexy. Now, having said that, what you shouldn't expect and what's not appropriate is what lots of people have described, both in this podcast series and what I see every day in people I'm seeing with narcolepsy, is that it's taken many years to get a diagnosis. But a realistic expectation would be starting with the common things, at least looking at those and considering those. But pretty quickly, if it doesn't look like that's the case or you don't respond to that sort of treatment, then looking at the next tier of things. Do you fit in that central disorders of hypersomnolence? And then looking at the next tier, okay, within that, what type of subcategory of sleepiness might it be? And could it be narcolepsy with cataplexy? And realistically, if you're working with your GP, that might be a process that takes 3 or 4 visits and 6 months to sort of work through. Now, that's a long way from the 10 years, 15 years often that people have gone through to make a diagnosis, so we don't want that. That's not appropriate. But it's also unrealistic, unfortunately, to expect to visit one, sit down and go, yep, this is absolutely narcolepsy, this is the only thing it could be. That'll happen rarely, but that's often when someone themselves really has worked out, hey, I've got all these weird symptoms and I can't put it together. And in 2025, there's lots of tools to help you to put weird symptoms together. Google, now AI, large language models, that people will now be coming to primary care going, hey, I've got all these symptoms, I suspect I might have X or narcolepsy with cataplexy. So yeah, that can often speed that up, but still there'll be a bit of a process of playing the numbers, remembering that narcolepsy with cataplexy is 1 in 3,000, 1 in 2 people are going to have sleepiness in the population, and 1 in 10 is going to have some form of hypersomnia. So it's just going to take a little while to work through those sort of diagnoses. So that sort of leads into well, what am I looking for when someone comes to see me? Now, that's a little bit distorted because I'm in specialist practice. And so the way it works in Australia is to come and see me. First, people have gone to see their primary care physician and gone through this process I've talked about. Playing the numbers is the way of sort of thinking about that. And it's only once it's starting to look like someone's in that disorders of hypersomnolence or a sleep disorder sort of range that they'll be recommended to come and see me. And so it makes my job way easier, right? It makes me look like the good guy sometimes, or makes me look like I know what I'm doing. Not that I necessarily do, but because a lot of the hard work and the ruling out the other conditions has been done. Lots of smart people have been thinking about what could this be, what couldn't it be, ruling out other things. And so it's a little easier for me in specialist practice because things have been sort of whittled down before someone's coming to see me. Now, the sorts of things I'm looking for is if seemingly sleep itself seems like it's a reasonable duration, reasonable quality, not perfect, but there's just consistent sleepiness during the day. So that's really a key feature for me when I'm thinking of people with central disorders of hypersomnolence, of which is the sort of overarching category that narcolepsy with cataplexy sits within. And so if someone's got that sort of core symptom of sleepiness during the day despite seemingly reasonable sleep, and, as we might talk about, people with narcolepsy have far from perfect sleep and in fact often sleep's really very disturbed and very chaotic and lots of other things going on during sleep. But if its sleep seems seemingly reasonable but they're still sleepy during the day, then I'm thinking about a central disorder of hypersomnolence. And at a very basic level, they come in a range of flavours or subtypes. And one subtype, the more hypersomnia subtype, the stereotype for that is long sleeping, sleep of the dead. Sleep for 12 hours, sleep for 16 hours, don't move a muscle, just out to it. And wake up and still feel like they could sleep more. Think of it an insatiable appetite for sleep. Whereas people with narcolepsy, often sleep's a bit different, so the flavour's a little different with sleep. Often sleep's shorter, broken up, characterised by more on the boundary of sleep and wake, so half awake, half asleep, which is where the sleep paralysis or hypnopompic, hypnagogic hallucinations come in. So sleep's not that sort of sleep of the dead, often in people with narcolepsy. In people more on the hypersomnia end of the spectrum, they often have significant sleep inertia, which is that can't get going in the morning. It's also seen in narcolepsy, but often a bit more in hypersomnia. And they'll often find naps not refreshing. So someone with hypersomnia, a nap is 2 hours and they wake up feeling horrible with more sleep inertia. Sometimes, not always, people narcolepsy with cataplexy, a nap will be 15 minutes and they'll get a little window of, hey, I'm actually pretty good for an hour or two before they start to get the, oh, there it is again, it's come back and I need to find somewhere to slink off and have another nap, because if I don't, it's going to catch up with me, in essence. So then that's the sort of thing I'm trying to look at, looking at the sleep itself in someone who's presenting with possible narcolepsy, is that sort of lots of sleep-wake disturbance and the sleepiness that's partially alleviated by short naps during the day, versus the hypersomnia, which is really long sleeps and sleep inertia and really unrefreshing naps. Now, they're the two stereotypes. They're the sort of ends of the spectrum. In reality, everyone's somewhere in between. So everyone's got sort of some features of those things, and it's rare that someone's right at one sort of end of the spectrum. Now, in terms of thinking of red flags that make me sort of think straight up about narcolepsy, really cataplexy is the key thing. If you think of what's a specific symptom of narcolepsy that no other condition gets, it's cataplexy. There's really no other symptom of narcolepsy that's specific for narcolepsy. And that's one of the frustrating things in getting to that diagnosis. The sleepiness is non-specific, the sleep paralysis is non-specific, the hallucinations are non-specific, naps, or naps being partially restorative, the disturbed sleep. All of these features are seen in other disorders. It's the cataplexy that's only seen in narcolepsy with cataplexy or narcolepsy type 1. So if someone's got a clear history of cataplexy, that's really about the only specific symptom that's going to make me go sort of straight to, hey, this could be narcolepsy with cataplexy. Otherwise, I'm really going to be thinking, okay, well, we're in the spectrum of disorders of hypersomnolence, and narcolepsy could be a possibility. And if there's that shorter sleep, broken sleep, partially restorative naps, lots of sleep boundary phenomena, then I'm thinking, narcolepsy's a possibility here. Cataplexy is really the thing that makes me think about narcolepsy. That's important because I'll often get referrals from primary care or people coming to see me saying, I've experienced sleep paralysis, I get some hypnopompic hallucinations, I can be tired during the day, therefore I must have narcolepsy. That's not the case, because those symptoms are pretty non-specific. They can get seen in a range of other conditions that can cause tiredness during the day and can also cause those, particularly conditions that are characterised by high degrees of nervous energy, or think of that as that high fight-flight response. So one of the archetypes of that would be ADHD. So it's not uncommon for me to see people with undiagnosed ADHD presenting with sleep boundary phenomena, disturbed sleep, feeling tired and fatigued during the day. Trauma, particularly early life trauma, so complex PTSD, that particular subtype of trauma, not uncommon to present with very similar symptoms to narcolepsy in terms of sleepiness during the day, disturbed sleep at night, sleep boundary phenomena, sleep paralysis, just not the cataplexy. But sometimes people with complex PTSD can dissociate and get transient episodes of dissociation that are brought on by strong emotion. And so that can actually be pseudo-cataplexy or look a bit like cataplexy, which can make it quite hard to differentiate. And so even though I've said, okay, cataplexy is my one thing, if someone's got symptoms consistent with that, I'm pretty confident it's going to be narcolepsy. Yeah, there are even mimics to that. So it's never something I'm really going to absolutely hang my hat on. And then if I'm thinking about, if someone sit in that disorders of hypersomnolence category, which is where the sort of narcolepsy and hypersomnia sit, versus other sleep disorders like sleep apnea or insomnia, it's tricky because lots of people with narcolepsy get sleep apnea too. Sleep apnea is really common in the population, and people with narcolepsy get insomnia too. So it is tricky differentiating these different sleep disorders. And in fact, some unpublished work from both my own practice and one of the large public hospitals in Melbourne that was done by one of our advanced trainees shows that lots of people presenting with sleep disorders have multiple sleep disorders. And part of managing them is working out, okay, what's number one, but what's number two, and sometimes what's number three, and managing the different aspects of health that are impacting on sleep and the different disorders they may have that are impacting on sleep. When I'm then trying to think about seeing someone for clinical assessment and the sort of questions I'll ask during an initial consultation, the times are evolving. So going back many, many years ago, we used to sort of think about taking a medical history and we'd be trying to sort of pump people with, right, do you have this, do you have this, do you do this, do you do this? But there's really very good work showing the best way of doing a clinical assessment is just leave the space open and let people talk. That's what I want to hear. And so rather than me drilling people with specific questions, okay, do you do this? Is this happening? Is that happening? I just want to hear people talk about sleep. I want to hear them talk about the experience of sleep. I want to hear them talk about the experience of wakefulness. How do they do life? How do they get through the day? What are the coping strategies they've developed? What are the things that have worked? What are the things that haven't worked? That's really what I want. And so it's almost got to sit on my hands or shut my mouth and stop myself from asking questions and just let people talk. And I'm also very fortunate in that in specialist practice, I have the space to do that far more than GPs do, unfortunately. And that's one of the challenges in primary care. But just listening to the way people describe what's going on with sleep, what's going on with wakefulness, how they get across the day is really rich. And I train lots of specialists in sleep and they'll sit with me and we'll see patients together. And that's one of the things I really try hard to teach them is just create the space, let people talk and just listen. Because once you've listened to enough people talk about sleep, I listen to a lot of people talk about sleep. One of the things I love about what I do because it's just a really rich life experience and you learn a lot about people. But that pretty quickly gives you a flavour about things. Now, I know that's really somewhat non-scientific and it doesn't lend itself well to a research approach where you've got to answer 100 questions and enter those fields in a database. But there really is a lot in that narrative history, just letting people talk and listening to things. Because the other thing that happens with sleep when it comes to then, okay, what am I going to do and how am I going to manage someone's sleep, is I really need to know what does sleep mean to them. We all grow up with these beliefs about sleep that are social and cultural, lived experience about sleep that shapes the way we respond and behave around sleep. For me to understand, what sleep means to someone, I need to get that before I can start to give them some advice or instructions about, how we might try and improve things. Because everyone's got slightly different beliefs, behaviours, habits around sleep. Again, what I really love about this area and what makes it really interesting, but it does mean that it doesn't always lend itself well to a very formulaic, one-size-fits-all, must follow this sort of approach. And similarly, if I'm trying to think of specific phrases or descriptions that signal narcolepsy, it's tricky. But again, my radar's on for the person who's always sleepy, no matter what. And again, the benefit for me, having seen people, unfortunately, after they've had years of symptoms, is that stability of symptoms. They've been through periods of stress. They've been through periods of busyness. They've had young kids. The kids are now older. They've changed role. Despite all that life experience, sleepiness is still there. And it's just been the constant presence that's there is a sort of a bit of a tell, there's going to be some disorder of hypersomnolence there. And then the types of things that make me specifically suspect narcolepsy with cataplexy is the cataplexy, so the sense of with strong emotion, muscle weakness. They just have this odd feeling. I try not to ask leading questions around cataplexy because it's so variable in how people experience it. For me, the sort of things on the radar is that chronicity, or that symptoms that have been very stable of sleepiness over time. If I do suspect someone's got narcolepsy with cataplexy, there's a number of diagnostic tests that we'll do. So the sleep-related testing that we would do would be an overnight sleep study, and that would then generally be followed by a daytime test called a multiple sleep latency test. There's a range of different sleep studies. So if you're seeing your GP in primary care, the sleep study GPs can access is a home-based sleep study, and often that'll be what people will be referred for. Unfortunately, in evaluating narcolepsy, it's a waste of time. that test. It's a waste of your time in doing the test. It's a waste of resources from a health resource perspective. Really, the purpose of the home-based sleep tests that GPs can access is to diagnose obstructive sleep apnea in those at high risk of obstructive sleep apnea. It's not validated for any other purpose, and so if the question is anything apart from does this person have significant sleep apnea and I think they're at high risk, then it's not the test to do. So try and avoid having that type of test unless there's also a high risk of sleep apnea as part of your presentation. The overnight sleep test and the multiple sleep latency test, in Australia, that's referred for that testing by a sleep specialist. So the pathway would be from primary care, see a sleep specialist, then they'd refer for that testing. Now, the overnight sleep study is where you go to the hospital, you have all the EEG electrodes and the airflow measures and things to measure muscle activity, sleep the night. The next morning, you wake up and then throughout the day, every 2 hours, back into bed and go off to sleep. And we only let people sleep for up to 15 minutes. That happens 5 times across the day, so it's a pretty arduous and weird sort of day. But what we're looking for is to try and put some numbers around sleepiness, so how quickly do people go to sleep in each of those 5 naps? And when they do go to sleep, do they go into REM sleep or do they go into non-REM sleep? Now, one of the characteristics of narcolepsy with cataplexy is that people will go into REM sleep in some of those naps throughout the day, and typically people with narcolepsy with cataplexy go to sleep really fast, like 0.5 minutes, 1 minute, that sort of time, whereas normal's about sort of 10 minutes or so to get to sleep. And someone without a sleepiness condition might sleep in 1 or 2 naps across the day. I'm a bit of a nap fan. I could have a little nap after lunch if you let me, but if I tried to sleep in the morning, there's no way I'd be able to go to sleep in the morning. But someone with narcolepsy will sleep morning, midday, afternoon, crash into sleep really quickly. So that's one of the tests that we would do. Now, there's some other ancillary tests that we'll sometimes do. So one is gene testing. So that's a HLA marker. That's a T-cell marker. There's a particular T-cell marker that's associated with narcolepsy with cataplexy, and as part of the immune response that we think triggers destruction of orexin neurons that's part of narcolepsy with cataplexy. So it's very unlikely that people have narcolepsy with cataplexy if they don't have that HLA marker. But 1 in 7 in the population carry that gene. So when I do that gene test, it's not to confirm a diagnosis of narcolepsy. It's much more to rule out a diagnosis of narcolepsy with cataplexy. So I'm more doing that gene test if I think there's another reason for their symptoms, but the rest of the healthcare team's concerned about narcolepsy, and I'll use that gene test. And if they're in the 6 in 7 of the population who don't carry that HLA type, then we can be pretty confident they don't have narcolepsy with cataplexy. Another ancillary test is measuring orexin levels directly in CSF, which is the fluid around the brain. Now, while we can do that, it's something we do very rarely. A couple of reasons. Doing a lumbar puncture is invasive. We have to put a needle into the fluid around the spine and drain a bit of spinal fluid off. And the second reason is getting the assay done is not straightforward. At the moment, we have to ship that over to Oxford. It gets run about every 6 to 8 weeks. It takes a bit of time for the results to come back and costs about $400 per test. Now, that's a test we may do a little bit more in the future with orexin replacement therapies that are currently in clinical trials, where we really need to know, does someone have a true orexin deficient narcolepsy in terms of trying to manage their condition. So they're the sort of common diagnostic tests that will be done with narcolepsy with cataplexy. And then just to give you an overview of treatment, there's a range of different treatments, but they would cluster into non-drug treatments and drug treatments. The non-drug treatments using behavioural strategies like napping is actually really important for people with narcolepsy with cataplexy. People with narcolepsy with cataplexy really find it hard to stay awake for prolonged periods. And yes, you can prop that up with medication, but that's only partially successful. And if they're able to build in even brief naps across the day, then we can usually get by with much lower doses of medications, which are then better tolerated and less side effects. So ideally, trying to incorporate napping or sort of periods of brief sleeps throughout the day is important. Also in a non-drug strategy, getting a diagnosis of narcolepsy with cataplexy is a big thing. It's really, people already know that they're having trouble with maintaining alertness and doing some of the things they really want to do throughout life. But having that diagnosis really means, this isn't going to go away. And so we'll often use psychology support and have people work with a psychologist just around that adjustment and what that means in terms of future employment, future relationships, future plans that people may have. Being diagnosed with a chronic illness is a big thing for people. When we then think about medications, they cluster into medications to try and support sleepiness and reduce sleepiness through the day, and for people with cataplexy, medications to reduce cataplexy. Of the medications to reduce sleepiness, we've got the psychostimulants, that's dexamphetamine, lisdexamphetamine, Ritalin, short and long-acting versions. And then we've got modafinil and armodafinil. For cataplexy, we have clomipramine, which is an old-fashioned tricyclic antidepressant. We can use other antidepressants like venlafaxine. And then drugs that don't fit perfectly into those groups but cross over with sleepiness and cataplexy would be something like sodium oxybate. Now, unfortunately, the hierarchy of how we have to use medications in Australia is we generally have to start with one of the psychostimulants like dexamphetamine. People can access modafinil or armodafinil if they're intolerant to dexamphetamine or if there's a reason that their prescribing doctor doesn't want to use psychostimulants for health-related concerns. We don't have access to sodium oxybate, and for cataplexy, clomipramine is what's approved via the PBS for cataplexy, but it comes generally with quite a lot of side effects. So I generally would prefer to use a low dose of an SNRI like venlafaxine. But if cost were no option, sodium oxybate for me is a much better option for cataplexy. Unfortunately, it's not a registered product in Australia, and so we've not been able to work through the process of trying to get it reimbursed. And that's an ongoing job that we're working on. So that's an overview of some of the treatment approaches and diagnosis in narcolepsy. Now, it's tricky when I then go to think about trying to educate healthcare professionals and I go, okay, how do I teach them about narcolepsy and how to spot narcolepsy and what do I wish they would know? So rather than trying to teach someone how to spot narcolepsy specifically, really what we try to focus on is giving healthcare professionals or frontline clinicians a framework for how to work with someone who's presenting with sleepiness. Because it is a matter of working through that sort of hierarchy of what's most common, what's next most common, and then when we've ruled those things out, what are some of the rarer disorders like narcolepsy with cataplexy that are going to be potentially causing symptoms? Because again, in healthcare, if everyone's starting with hey, you've got this 1 in 3,000 condition, they're going to miss the more common conditions. And so that's just the way we have to work in healthcare, is start with the most common things, but not keep banging on those common things if things don't respond. It's you start there, but then you move on to the next thing, and then you move on to the next thing. So that's why I really want to work with clinicians on a framework for managing sleepiness and fatigue. And that's where you may see, if you're looking at some of the articles that both professional societies and myself have written for GPs, they're very much about approaching the patient with sleepiness or assessing someone with hypersomnia, rather than this is specifically how you manage narcolepsy with cataplexy. Because we don't expect GPs to be experts in narcolepsy with cataplexy. We just need them to know, hey, something doesn't smell right, this person's sleepy and something doesn't add up and I need to refer them on. That's really what I want. And another thing I really want a little bit more for people who have narcolepsy, if they're thinking about what you need in your GP, it's important to understand you're not going to find a GP who's expert in narcolepsy with cataplexy, but you want to find someone who's open and is going to go on that journey with you, in essence. So he's going to listen to your symptoms, validate them by, acknowledging, hey, this is real, we're going to get to the bottom of this and we're going to work through a process, and once I get to the end of what I can do, we're going to look at referring you on if still we need be. And who's going to just go on that journey with you, because they're not going to be experts, but they'll learn to become experts and you'll be part of teaching them to become experts about narcolepsy. Because thankfully, there's lots of resources available for people with narcolepsy, including this great series that Di's putting together to really help people with narcolepsy understand more about the condition, how to manage symptoms, and they can therefore be advocates helping other people with narcolepsy understand that, but also helping healthcare professionals understand that. So then, along the similar lines, if I'm then thinking about any sort of guidance to healthcare providers who don't specialise in sleep medicine and want to sort of identify narcolepsy, this will seem a bit backwards. The message that I try to give people is not everyone who's sleepy has narcolepsy, because the word narcolepsy gets used a bit inappropriately in healthcare. It gets used in the sort of Homer Simpson version of narcolepsy, or the Hollywood version of narcolepsy, or narcolepsy is this all-encompassing term for anyone who's sleepy for any reason. It just gets called narcolepsy, because that's the sort of word that people have heard of that describes sleepiness. But narcolepsy with cataplexy is a very specific neurological condition. It's not just that sort of broader sleepiness. So that's where I do want people to have that framework of, okay, there's this sleepiness condition there. I've gone through things like thyroid function and iron, and I've checked off mood, and they all look okay. It looks like there's a sleep disorder that's causing this sleepiness. Okay, then I'm going to refer on to a sleep specialist. So for me, it's thinking about that framework rather than trying to train people to be experts in identifying narcolepsy. It comes back a bit again to, what do you want out of your healthcare provider? You want someone who's open. You want someone who's you come to them with, I think I've got this and this is what I've read. You want someone who goes, yeah, okay, that's possible. Let's work through that, rather than, oh no, it couldn't be that. It's going to be this, and goes down a completely different line altogether. I got desensitised very early in my career to people coming with lots of printouts from Google. I worked in Boston at Harvard for a couple of years, and that was in the tech boom around the early 2000s. And lots of people coming with lots of information from the internet about their conditions. And I got pretty used to that, far from being threatened by that. And in fact, I really enjoy that. I've got to tell you, as a healthcare provider, it's much nicer to have an informed discussion with people about things, and that's really where we should be in 2025, rather than that sort of older paternalistic approach where I'm the font of information and I'm going to be the one sort of telling you information. It's a much more collaborative, should be a much more collaborative process now, particularly as there's that ability to access information is much more democratic in this day and age. So hopefully that's helped understand some of the process and some of the thinking when you're going to see a healthcare provider with sleepiness or potentially with what may be narcolepsy, and might help alleviate some of the frustrations, but give you some insights into just how that sort of process works in terms of, how the healthcare providers are thinking about things and some of the other symptoms that we're sort of thinking about when we are trying to diagnose narcolepsy.
That was Dr. David Cunnington, offering clarity, compassion, and clinical insight into narcolepsy with cataplexy. David's message is clear. Diagnosis is a process, not a moment. It's shaped by probability, persistence, and the power of listening. And while narcolepsy is rare, sleepiness isn't, making it all the more important to have a framework for working through symptoms, rather than chasing certainty too soon. If you're a patient, know that your story matters. Your ability to describe your sleep, your wakefulness, and your coping strategies isn't just helpful, it's diagnostic. And if you're a clinician, remember that you don't need to be an expert in narcolepsy. You just need to be open, willing to learn, and ready to walk the journey with your patient. This series was created to honour that journey. As we close, remember, if you or anyone you know is experiencing ongoing sleep issues, then please speak to your doctor. The Waking Up Tired podcast exists to raise awareness, foster understanding, and help others find the diagnosis and support they deserve sooner, not later. Thanks for listening to Waking Up Tired, Narcolepsy Symptoms Explained.